role is I'm on the Child and Family Behavioral Health Unit, and I oversee MRSS, and which is the 20 and under crisis response system. So responding to youth looks a little different in this model than responding to adults. It's really trying to shift the front door of children's services to sort of be on that preventive side. And attached to the initial, if we're going out to children in the community, we don't want to just go out in crisis. We want to go out, help resolve, and then connect them as soon as possible to whatever services we need so they don't end up being high utilizers once they become adults, right? Earlier is better. So with that being said, I also oversee IIBHT, which is the Youth Intensive Services, so community-based services. Heidi and Erica had some questions that I may or may not be able to answer, but why don't you give it a shot about Red Cap, maybe, I think it was.
Well, Erica, do you want to find, we're basically our question, because we are such a small community, our adult and child crisis response, it's all the same.
Mm-hmm.
And we provide the services here. You know, we don't have to like refer the kids out to other areas.
Sure.
We take care of all that. But I know Erica had some questions about the reporting part
Sure.
of that. So Erica, do you want to go ahead and ask your questions?
First of all, do you have a specific template that we should be using for reporting quarterly to you?
For the stabilization services, yes, there's a separate one that's different than the MCIS one. Do you have the MCIS one?
I don't think I have it.
Okay.
I think there's just been using what we do for our Gobi, but.
Okay. Yes, there's specific templates, and there's a data dictionary that explains how to answer all of the data points that OHSU completed, and you work directly with OHSU, and they want to make it as easy as possible for you guys to get them the information. So OHSU has an email address that you can just communicate directly with them. You always send those templates over to OHSU rather than sending it to us. And what OHSU does is they take your data, they at the end of the quarter, they take your data and they make a report for you and for the state. And then they submit that on behalf of your agency as it's a requirement in Service Element 25. And it's also, there's a reporting requirement in Service Element 25A. So OHSU takes your data and they make it into usable information, and then they submit it to us on your behalf so that you don't have to submit directly to OHS or OHA. And that's how you get funded. That's how and then we track that it's been completed, and that's what prompts the service element funds to go out.
Okay, and do you have that email?
I do, and I will email it to you. And Maya probably doesn't know it. Luke Todd, I'm going to ask you if you're listening. Can you put the email address in for mobile crisis for OHSU if you can find it? I believe it's mobile crisis at OHS information at OHSU. If not, I will look for it in a moment, and they will get you all set up, Erica.
Okay, thank you. And our second biggest question is, because we are here, we don't have a two-person team. We've heard back and forth, like, yes, you do record and then report those, even if you aren't a two-person, but then we've heard, no, you don't, because you're not a two-person mobile crisis team.
So you mean on the data forms, like in the data? Yeah. No, there's places on the data that, yes, you want to get, we are counting all mobile crisis dispatches. And there is one of the questions is on the dispatches, are you dispatching one person or two people? And if it's two people, it asks you a couple specific questions, but yes, we are really trying to collect, we want to know how many dispatches, how many times is your team going out? And we also already are working with all of the agencies submitted an attestation. And so we are well aware of where all of the counties are at trying to build up. And Heidi and Erica, are you from
Lake?
Lake. So Lauren was just out there and she is well aware of some of the issues going on that you're trying to resolve, and things going on behind the scenes. So we are setting up quarterly meetings to just follow up and do technical assistance, but absolutely understand you guys specifically. She did pass along that she is really, thank you, Stacy. Stacy put the email address in for OHSU in there, Erica.
Oh, okay, thank you. I got it.
Yeah, and if you have any issues, they're pretty they will respond. They're pretty, Lydia is the lead for MCIS and MRSS data collection. So she'll get back. Someone from that team will get back to you.
Perfect. And our last little question to this is, is there a spot in there too for phone? Because a lot of our crisis is handled over the phone. A lot of our people are just, they're wanting that support over the phone. Do we report the phone or no? The phone calls.
Is it coming through your crisis crisis call center?
Yes, it's still our crisis.
Yeah, so there's a memo that went out to all of the crisis call centers. We are asking them to collect data so that we can get an accurate number of how many calls did they get in. And one of the questions, it's very simple data set. It's not like what we're asking the teams to do. We're collect that for the next couple months just to get a better idea of the flow of calls that come through there rather than 988. Because right now, 988, we're still transitioning to using 988. So there was a memo that went out specific around what data you need to collect and where that goes. That was from OHA. So if you didn't get that memo and you have no clue what I'm talking about, I'll find it and forward it to you.
That would be great. Thank you.
Okay.
And I think that covers, I think that's our big questions, right, Heidi? Did I miss something?
No, I think that covers it. So long as we have the reporting templates and know where to send them and what to report, we should be good. So we just had some confusion there.
Yeah, there's Excel spreadsheets that for MCIS and Excel spreadsheets that you submit, and OHSU, and I can't speak to, they have tried to make it as individualized to work with whatever works for you all. And so they will talk you through that process and figure that out with you all. But again, someone must have submitted some data because I already saw your reports. So I'm a little confused. Yeah,
we did. We just weren't sure if we were doing it correct, or I wasn't sure if we were doing it exactly. We've come back where we've had people be like, 6 months later, this isn't correct. And well, you were on the phone. I'm going to make sure.
Okay, nope. So that's your best bet. Yeah. So I did see that they had gotten information and they are sending reports out, I think today. So the report should have went out already, but we had a little glitch with contracting. So the reports are all going out now because of, just remember, some of you all won't get individualized reports because the numbers are so small. There is like a suppression because of protected health information. And so I don't know all of the logistics about that because we're still trying to figure it out. But folks should be getting reports. I think we said the 15th, if I'm not mistaken. So you might see those today, or if not in the next couple days. So yeah, thank you. I didn't hear that you were doing it wrong, Erica, but it's always good to double check.
Okay, good.
Yeah. And also that stabilization services, we did not get very many counties reporting anything for stabilization services. So that's good to double check. All right. Well, wow, I actually answered those. That feels good. I actually knew something about something. So if you're just joining, there were no questions submitted ahead of time. Luke, I don't know if you want to say the answer to your TS. And so TS is the modifier that we're asking you to use. June, okay. Sorry, I got sidetracked. June Bennett. The TS, so once a youth is, if a youth is going to be seen in stabilization services for those up to 2 months, we do ask that whatever codes you use, you also use TS. It is not at a higher rate right now. It is at the same rates as the outpatient codes for the stabilization services. So we're asking that you use the outpatient codes, but use TS so that we can see, that the child was not a typical outpatient. Also, the point of and we realize that there are some youth, because stabilization services is open to private insurance youth as well. So remember that stabilization services is about prevention and trying to assess what's going on with youth and hoping that if they need mental health, we can connect them with mental health. But sometimes families need a deep assessment and need somebody in there to help figure out what might be helpful with to support the family so it doesn't escalate further. So questions from anyone about, remember, MRSS is really my wheelhouse, but I am happy to find other answers for you and get back to you today if anyone has anything else. Any questions? Does anyone want to ask anyone else for any brainstorm? Does anyone want to have something on their brain or they want to ask the other 20 people in the room?
Beth, I'll just pop on too. If folks hadn't seen the chat, I am here. So if there are billing questions, I'm happy to take those as well.
Oh, okay. Now you opened it up to billing questions. Does anyone have a billing question? And Luke, I'll throw out the disclaimer that sometimes we have to research these and that we do want you guys to be submitting questions ahead of time when possible. So we can do our research, but. Anything?
Hi, my name is Christine. I'm in Douglas County, and I am brand new to this. Where I'm the first one. I'm the trailblazer out here.
Nice.
And so I have a decent amount of questions, but I feel that they will be quite redundant for folks that have already been doing this for a minute.
All right. Yeah.
What's the best way for me to just coordinate with somebody or just shoot off these random questions as they pop up to me, as opposed to kind of utilizing this whole time where maybe everybody else already knows what they're doing?
Well, so there's a couple different ways. One is I'm happy to answer some of your questions here, and MRSS is new to everybody. Typically, this format, we ask that you use there's a link if you scroll up in the chat. Maya at 10:04 put in the email. There's a form that you can formally submit questions to us via. So what happens is those questions come directly to our team. We figure out the answer. We email you our response and our answer. But then what happens is the following month, we put it into a slideshow and we go over all questions for everyone. So these folks are actually here. People who didn't submit questions come to office hours to hear what other people might have submit, because we're all learning together. So so that's the typical process. You can always set up a time. I'd be happy to meet with you. I'm overseeing anything to do with youth, the youth sort of 20 and under mobile crisis, which is a little bit different model than the MCIS, the adult crisis system. My co-partner wasn't able to come today, but usually he and I are both here, and then we usually have someone from Medicaid. I'd be happy to meet with you, or if you have some questions, feel free to ask them right here, because MRSS is new to everybody. So.
And I'll just echo that. Yeah, if it's easier at whether you ask questions today or not, if you want to schedule some time, with Beth and I and Rick as well, perhaps. Like, sometimes it's just easier to have those one-on-one conversations, especially if you're kind of coming in on the ground up, and we're happy to do that when that's helpful. So
yeah, I think I'm a big fan of what you just said, Luke. So yeah.
Yeah, we're happy to help, Jennifer, however you want. We can have one big meeting and go over stuff together, but just email. And if you have little questions along the way, you can email them to me and I'll let you know if you need to submit, if I need to do research on it, if it's a big question or it's not, if it's about licensing or some of those bigger topics, I sometimes ask you to fill out the form, but if it's just simple stuff, we also have a billing FAQ if it's about billing, so.
Okay, yeah, I think I'll start with that. Thank you, Maya. I'll start with those individual emails to you, and then you can let me know. Being the first time I'm on this meeting as well, it's so hard to know what things have already been covered a bajillion times. But like
Yeah,
I said, we're all still learning. So okay, I
we
appreciate that.
are.
I'll start with those emails and then I'll start to get the gist of what these monthly meetings are about. And then yeah, I feel like
Yeah,
I'll get the hang of it then. So, okay,
we'll
thank
get you there.
Okay.
With that being said, and welcome Jenny to our messy crisis system we're trying to get up and running. It's these guys have been working really hard, so we're happy to have you. Maya, I don't know if you have an answer for, I know we got at least once there was an error. People were getting error codes to watch some of the recordings, and I'm not sure if we fixed that or if that was an issue, but Misty just put that up as well.
No, you can't watch them from the Teams. That's why I usually send out
Oh,
emails
yeah.
with a YouTube link, so therefore external partners can watch them.
Yes.
I can try and compile the last, few months of recordings and send
Oh,
them in an
great.
email in the next few days to make that a little easier.
Okay, great. Yeah, you can't watch them in the channel here. We have to convert them to YouTube, and then Maya sends them out. So you have to look at her email and the link. Again, though, things have been changing so quickly. I wouldn't go back and watch even past about 3 months, the last 3 months, right? So, but yes, you have to the YouTube links. And of course, I didn't record today's because we didn't have a spreadsheet or we didn't have a formal. Today was just kind of a one. Oh, you are? Okay. Well,
Yeah.
I don't know that this
Sorry,
one
Beth.
only. That's all right. I just have to watch my language now. Other questions?
Beth, maybe while folks are thinking of any other questions they might have, can I talk about just the updates that were made on the billing guide real quick?
Oh yeah, absolutely.
Awesome. Cool. So the main thing that happened with the billing guide is there's some new content at the end, some appendices that kind of break down mobile crisis billing by in a couple different like provider categories. So some of your agencies have submitted that provider specialty enrollment form. And so it tells you if you land in that enhanced MCIS category, how to bill. If you're regular MCIS, how to bill, or if you're a CCBHC. Each of those is a little bit different. And also, if you're in that category where you haven't yet been certified for MCIS and are still just billing in that old mobile crisis category, how to build there. So that kind of like separates out some of the content that's all kind of mixed together up above about how the different providers build to like break it out just by sort of the specific situation or like provider category, for lack of a better term, that your agency is in. So that's new content. The other piece that is finalized now that we've been talking about for quite a while is the telehealth in place of service could be. So something that I think many of you have heard is that we were like looking at this change, and it is now official that for any let me look at how I actually worded this here. Any mobile crisis response with an in-person element is going to have the place of service code 15 for mobile unit, and you're only going to apply those telehealth coding rules if the response is 100% telehealth, meaning there's no in-person requirement. So from where we started, which was pretty complex, multiple detail lines for breaking down the different ways to kind of try to track the balance between in-person and telehealth responses, we've gone kind of all the way down to the simplest we could do, which is to say if it's only telehealth, 100% telehealth, code it as telehealth, otherwise don't. So really for mobile crisis responses, we're talking about those those follow-up responses that are allowed to be just via telehealth that don't need to have an in-person response. If you just are on the phone with someone, code that as telehealth. Otherwise, you're coding it just according to sort of the regular mobile crisis rules and leaving those telehealth place of service codes and modifiers aside. Any questions on that? I'm happy to take them, or we can go back to regular programming.
We still have about 30 minutes left, so again, happy to answer any questions, or we can end early. When can I review the latest billing guidelines with the updates you mentioned, Luke? Is a question in the box for you.
Hi, Misty. The link is in the chat, just 5 or 6 chats up. You should see the link there.
It's at 1022 from Luke. It's that one. Well, all right, I'll stay on in case there's anyone who wants one-on-one attention or doesn't feel comfortable asking a question in front of the, oh, Sarah saved, here you go.
Hey guys. I am so sorry. I had another conflicting meeting, so I had to pop out at the beginning and I missed a
Oh, yeah.
lot, which is such a bummer for me because I
Mhm.
really appreciate these meetings and hearing from everyone. One of the things that I am hoping to track down is more data on like percentage of population served as we're building out our service here in Lane County. We don't have a lot of good data to work with. And so we're kind of starting with um, some very transformed data and also, just some assumptions that we've been building in. And I don't know if other folks on this call from other counties are willing to share their encounter data with me. But it would be really, really helpful. Deschutes County has kindly shared their information. So Adam, if you're on this call, thank you so much for that. And it's really just to kind of get a sense of the trends across the state, what people are encountering. That's really what it would be used for, is just to help inform my modeling as we plan out our operational modeling across the county. So that's just a
Have
plea.
you
And
seen the data reports will go out today for each of the counties, and this is the first quarter that we've gotten. There was no data collection required at the state level during COVID, and so we just resumed, and so we don't have a lot of historical at OHA. So if these folks might have still collected data, but you guys will be getting your data reports, which includes the statewide data report as well.
oh, okay. So is it
That'll come out
broken
to,
out by county? Is it broken out by service area? Is it something I can reference against populations?
there's a heat map and things that shows
Okay.
all of the urban broke down more by urban rural. We try to keep the specific county stuff to their specific reports. So each
Yeah.
county gets their own report, but they can choose to share that as they see fit. But this will be the first time we're doing this. And so they were a little delayed due to some glitches, but maybe once you see those reports, it'll give you a better idea of what's going on. And you should have one for all of your 3 providers as well right now, whoever's submitting data from your side. And I know you'd been working on it, so I'm not sure what that looks like. But did you get the data? Have you seen the data reports from the previous quarters, Sarah, since you've been on?
I have seen
Okay.
them, and it
Okay.
looked like it was just our data,
Yeah,
but
I
it
think
could
this
be
is
the version I was getting. So, okay, cool.
no, we keep expanding it, and we didn't have a lot, we were building up, but this quarter we do have at least some quarterly data or statewide data that's going to go out this time to everybody too. So it'll be
Okay.
the first time this report, and then they just keep updating it. But I think they're going out today, if I remember correctly. But
Awesome.
yes,
Well,
I think
that'll be wonderful.
yeah, well, I think what I heard though is Sarah's asking if you guys would be able to share your state. We won't share. OHA doesn't send your state report, your specific county, your stuff. We won't share that with other counties. That's up to you guys to share with the counties. We do have a statewide report though that has some information
Yeah.
on the statewide trends. Yeah,
Cool.
we're also trying to figure out what we want to do and how we want to look at the data that's statewide and look at trends and things in our current system. So we're also thinking through how we want to do that at a larger scale. So not only do we encourage you all to do that internally based on your reports, we also are thinking about the larger implications as well.
Mhm. Yeah, I mean, it's interesting because finding, what is a comp to Lane County? Lane County just appears to be unique in myriad ways.
Yeah, yeah, well,
And so it's been a little bit of a challenge, but I think one thing that may be interesting, Beth, as you guys break this out,
mhm.
is if you break it out by the frontier rural
Yeah, it
metro.
is. The heat map has,
Perfect.
I mean, it
Very
all
cool.
has instead of doing it by county specific, a lot of the data is broken down that way by rural frontier and then, yeah,
Yeah,
and
totally.
response times and things like that. And so, yeah, take a look. And again, sometimes OHSU collects more data than they end up reporting because of PHI, but it doesn't mean that we don't have some data that might not show up in the reports, right? So more to come on that.
Cool. Thank you.
Yeah. I am excited about looking at the data. I've actually had a glance at it already and have like 25 questions written down that we also are going to, just so you guys know, we are setting up quarterly meetings to follow up with all of the counties. So we have almost everybody has responded by now and has set up a meeting. And so Lauren and I are going to come out every quarter until for as long as we need to, but just checking in on a quarterly basis to see where folks are at in this process. And one of the things that we are going to bring with us to those meetings is also any trends that we saw in the data reports that are unique to your county, just to see if it's, have a discussion about as well. As we move forward and sort of continue to fine tune the data. And remember, OHSU is a workaround right now until roads gets up and running. So eventually OHSU, the goal is for you guys not to have to submit data to OHSU via these spreadsheets. The goal is that it's all in roads, which is replacing MOTS. And so internally, we'll just have that data. We can pull whatever we want. And so the goal is not to have you guys continue to do those Excel, although the timeline is always sort of a moving timeline for when that's going to happen. So anything else?
Beth, I don't know if you saw Mary's question in the chat.
Don't.
It's around and Mary, I'll just say that note in the billing guide is reflective of a memo that was sent to CMHPs back in February. I think this is the one that kind of like explained the attestation process and how it was going to work while both rule sets are still active. I will say I know the intent is that, the those old rules are no longer in effect as of 1/1/25, which would mean the MCIS rules are the only ones that are operable, sort of guiding how mobile crisis services should be delivered. And as they currently stand, they only allow for a 2-person response. So I don't know if you're thinking of an agency that like hasn't been able to fully implement NCIS yet, or if there's some sort of staffing issue that results in a 1-person response, or even that in some cases, I think, like what if it's a response to a hospital, or so I would say I don't know the answer yet. Excuse me, in terms of what will happen with the CG modifier. But I will say directionally, MCIS as a model is a 2-person response. And so I guess it's like we haven't determined exactly what will happen, but the plan is still that those rules are taken, the old standard and sort of the allowance for operating some combination of the models is supposed to go away as of 1/1/25. I don't know if that answers your question.
It
But
does to
that's
some extent, and I guess I think there will be situations where there can't be a 2-person response, whether or not we're still trying to hire for our teams, whether or not it's a certain time of day where we don't have another staff who has been trained under the OARs to be part of that MCI team. It might be somebody else who goes with them. There could be situations where as soon as January 1st, 2025, which will be here before we know it, I'm just wondering what then when we have a 1-person response, or even in the hospital, or if it's a situation where one person could safely arrive there.
So Mary, Mary, on the attestations that went out, that was one of the questions we asked, was what the current status was. And one of the things we'll be working with when we meet with your teams quarterly is what that looks like and what'll need to happen. There are ways to bill for that 1-person going out, but whether or not it's MCIS and how that's going to look and what we're going to do, and if you need to file for a variance or what that's going to look like starting in January based on hiring, I think that's some of the things that Lauren and I will be providing technical assistance and working alongside you. Right now, the attestations just asked, especially for overnights, there was a clause that said we're still giving you all a COA and approving based on your attestations. If you were, depending on each county was different, but we looked at the attestations, we reviewed each one as individuals, and then we have noted what your current ability is to do the 2-person team. And we also have flexed for the overnight for now, but that's what we want to do is it's individual, and each of the counties have such different stories to tell and populations that they're serving. So I think that Lauren and I really want that to be a collaborative process and part of what we want to talk about when we meet each quarter.
That sounds great. Thank you.
Yeah. Because we also know that there's we also are well aware that you all are usually sending 1 person to the hospitals, and that's something that isn't in writing and doesn't meet the model, but we also understand it's a safer environment that's contained. So we also are trying to figure out what we need to do, because it's not easy to open the rules. So what do we want to do, and how do we make sure that people have the ability to make some clinical judgment in those situations? And we're just not there yet. But we do know that you guys are lots of times sending 1 person to the hospitals.
And just to that point, Beth, when it comes to that flexibility, I think you're speaking from the program side. I think obviously we need to spell out how exactly it works or when that's permissible at some point. But from the billing side, from the Medicaid side, we have to stick more to the letter of the law. So you wouldn't, if you do send 1 person to the hospital right now, even if you're fully up to speed with the MCIS model, you can't bill for MCIS when you send a one person, because it doesn't meet those criteria and rules. So again, the higher rate only goes to a service that's meeting the standards outlined in rule. So
you have to have 2 people. You have to have 2 people to get the new rate. But hopefully you guys are aware of that. All right. What about if we send 2 people to the hospital? Yeah, if you send 2 people to the hospital, as of right this moment, it qualifies as MCIS. And so if there's 2 people, right, Luke, that they can bill. Well, now, again, I don't know what we're going to do about that long term, but as of right now, that's my understanding. Is that
Yeah,
correct?
that is available right now. I do think at some point we'll probably like untangle that as sort of a
Yeah.
different service, because I'm not sure it's quite MCIS in the same way. But yeah, right now that is allowable under the rules.
And some of you all know, Lauren and I and our team, we're working really closely with our public health partners right now and to really figure out what needs to happen in the emergency rooms and how to make sure you guys are getting reimbursed for your services when you're going to the emergency rooms and how that all plays out. So we're hoping to, we're getting closer to having more information about that. But right now, you guys, if they fall under the MCIS response, and we realize that's part of the reason we're having you guys track response to jails and hospitals is because we're really trying to get a better grasp of how much of your time is being spent outside of what we would consider like open community environments, right? So I know that's different than in the past, but that data has been really valuable for us to see. I think somebody pointed out we had, I can't remember the number, but let's just say we had 8,000 or it was close to 8,000 responses last quarter across the state. And to be able to see what percentage of those are actually to hospitals where people are coming through the front doors. And then, of course, we want people to go to the emergency room if they need to, but we also want to know what it would take. You know, once 988 marketing goes live, we haven't started marketing in the state of Oregon. As you guys know, there's not any Oregon specific commercials or anything that we've done yet to advertise for mobile crisis and MRSS or 988. So we also will see what happens with people if people become more comfortable with having you come to their home rather than the hospital. Who knows, though? That's why we're collecting the data. We don't know. We don't know. Go ahead, Heather.
Thanks, Beth. I just wanted to clarify before we just got enrolled. We got approved as Douglas County. And so just to make sure we're sending our services out correctly and billing them correctly, anything prior to that approval date, are we allowed to bill those services with the CG modifier? You probably have answered this before, but I just want to make sure. Do we have to hold
You
off
mean
on the CG modifier until we're
The
you mean
CG
you were
modifier.
approved? Sorry, go ahead. Yeah.
Oh yeah, I was gonna say the CG modifier is for Mobile Crisis, the old standard. So that's anyone that's been billing for Mobile Crisis over the last, year or whatever should be billing H2011 with the CG modifier for Mobile Crisis old standard. To bill H2011HE for MCIS, you would need to have had the 309072 rules added to your COA, and then have one of those MCIS provider specialties added to your provider record in MMIS, and that's what's going to allow you to bill at the higher rate. And it would be back to the effective date on your COA. And we're matching right now the effective dates for those specialty enrollments with your COA date. So that's when you could start billing for MCIS, but not retroactively.
okay? And the COA is that initial approval that we received. I think it was 327 for Douglas County, but okay, that makes sense. That's how we had been doing it, but I thought I started to doubt myself since we got the go ahead to go forward. So thank you, Luke and Beth. I appreciate it.
Mhm.
This is Mary again. Really quick, can I back up to what someone else asked about if we send 2 people to the hospital? And you said right at this point in time, if we technically sent 2 people to the hospital, it would be MCIS. Does that include other quote unquote facilities or treatment facilities? If we send somebody to a primary care office or a secure residential treatment facility, does that also count at this point in time?
The rules, as I read them, Beth, jump in if you have thoughts here. But the rules don't exclude any locations from an MCIS response. There are certain locations excluded from so for the subset of providers that are doing enhanced MCIS, you have to apply a modifier to tell us if the services were rendered outside of a hospital or facility setting, and that's used kind of on the back end of Medicaid claiming for an enhanced federal match. But that's, again, just about what percentage the state gets from the federal government, and it doesn't impact what rate you get paid if you're rendering MCIS. Anything to add or clarify to that, Beth?
I would just say that the if you look at the OARs, if you look and read the definition, it includes there's more settings that are included in the 09 or 30919 rules for CMHPs. There's more settings, and so that's why we have that. In the new rules, it's not as clear. I also think that I would say it's not, you guys know, it's not an easy process to open up the OARs, but there does seem like we need to have some we have a running list of things that probably need to be clarified in rules to make them make more sense across the board. And that's sort of one of them as well.
Okay.
Does that help, or have we just confused the heck out of you?
No, it does help. For whatever reason, I was under the impression that we were excluding hospital, jail after they'd been there beyond the first day.
Oh.
Secure residential treatment facilities, other locations that we thought were quote unquote facilities.
Well, that is
correct.
So I will say that the facilities that there are many facilities like psych res and some of the elderly memory care. So we have had discussions in the past. Memory care and residential are supposed to have their own crisis response internal, and that we do, if you are having to respond there, I would encourage you to set up or have a discussion with their leadership. For children, you guys should not ever be going into a psychiatric residential facility for a youth. You should not be going to the farm home. You should not be going to Albertina Kerr. You should not be going to some of those facilities because they have their own procedures and policies, and it's a locked facility. Jail and hospital has been really questionable. We're including those in our data because we are trying to figure out how often you guys are going to jails and hospitals, because we also are trying to figure out, is that really part of mobile crisis? Because you guys know, when we think of mobile crisis, we're thinking of community, but we also know that you guys have established relationships. Some of your counties are getting paid to go to the hospital outside of what we're giving you for MCIS, and some of you are not. So we are working with public health right now to figure out how we can help you guys make sure that we are very clear on the hospital and jails, but please keep doing what you're doing with them and collecting the information at the front part so that we know how often much time you're spending in those settings. Does that help, Mary?
It does.
Well,
should I just stop asking questions? No, I'm just kidding.
No, in the very beginning, like 3 years ago, a memo actually went out when Angela James was still my partner on the adult side. We sent a memo to some of the facilities letting them know that they shouldn't be the locked facilities, that they needed to access their own psychiatric processes. I haven't seen that. That was a long time ago. So I'm just curious as to.
And Beth, I'll say, I think it's one thing to tell those facilities that they shouldn't call mobile crisis because they should be able to handle it internally. And then a separate thing to say, if that happens, can the mobile crisis team bill or can they respond? And I think like the hospital problem is so widespread, but really it's a similar situation, right? It's the hospital's responsibility to do certain things. And I know we intentionally wrote the rules to say to define sort of community-based as the location of the person in crisis, which is, I think, broader than we want to be ultimately, in that ultimately we do want some of these facility and hospital settings to be able to address a crisis that arises in the setting. And at the same time, knowing that that's not the current state, we didn't want to sort of cut off that either the service delivery or the billing for it when appropriate. And so I think to your point, that the language that you were using, Mary, reflects my understanding of the language that used to be in the billing guide around when the HT modifier would need to be applied, which really was, as we've broken it down now, is not applicable unless you are an enhanced MCIS provider and you're at options, right? Anyways, so for most providers that are just doing the that will be enrolled as a, sorry, I'm stuck trying to think through where you're, but you're a CCBHC, I think, instead. But anyways, the HT modifier is only available or only applies to a subset, and it doesn't impact the rate that you get. And that's when you would have needed to sort of like select out for those hospital and facility setting ones. And that's, I think, not relevant for you anymore. And I may have just confused that more because I think I confused myself while I was talking. Sorry.
And the jail piece, so that it's helpful. I'm piecing this together as things sort of change and expand. But in reference to the jail, if I'm not mistaken, the most recent FAQs explain that if there's a behavioral health crisis at a jail, that we could bill that on the first day if somebody arrives, but then because their OHP ends the next day, anything after that, we couldn't consider that mobile crisis intervention. So that also sounds a little bit particular and unique, and we'd have to keep that in mind.
That's only because they lose their Medicaid benefits. Right. So you can try and bill, but they're going to get rejected once the system catches up with you, because they'll say they no longer. You can still serve them, but it would be using your service element funds.
Yeah, and you're right, Mary. That's one that everybody has to pay attention to. If anyone responds to jail, that's kind of just completely different from that hospital facility setting, because it's about loss of benefits as opposed to, is this particular setting one where we can render the service. I just double checked, sorry for the run around on my confusion earlier, but yeah, as a CCBHC, you don't have to worry about that setting that you're responding to, whether it's a hospital or an SRTF or any of those. Again, if you're called there to do a mobile crisis response, that's not going to change your billing for that.
Right. That yes, I do understand that. As a CCBHC, we're under sort of different guidelines around that. Yep. Okay, that is helpful. Thank you both. I hope I didn't confuse anyone either. Thank you for addressing that.
Well, it's about as clear as mud, right? Like, and we acknowledge that. And we also, it's really hard because we have two different rule sets up and we're moving from sort of old standards while trying to like build the ship while we're going to the new rules. And we already, a lot of this stuff needs to be cleaned, a little bit of cleaned up. So no, keep the questions coming. We'll get there. It's all complicated. Well, I guess we used the whole time, you guys. It's 5 minutes till. So for our staff wellness, we always want to give you 5 minutes to do what you need to do between meetings. So I'll hang on for a couple more minutes. Otherwise, I'll see you all. The MCIS Learning Collaborative will be next week on the 22nd if you partake in that. And I'll see you guys soon. Thank you.